In this section, we are going to see one of the basic hemolytic anemias, that is hereditary spherocytosis. Why I told basic is not because it's very common, but it's one of the basic keys in understanding, and that's why it's very important topic for the exams as well. Hereditary spherocytosis. So, what is the problem in hereditary spherocytosis is this, which we have discussed already in the basics of the red blood cells, where you have a defective RBC membrane. The membrane cytoskeleton is defective due to mutations in a lot of proteins. But if they ask you which of the protein most commonly mutated in a patient with a hereditary spherocytosis, your answer must be ankyrin. Ankyrin is the most common mutation that results in hereditary spherocytosis, or you can tell it as hereditary spherocytosis is due to mutations that happen most commonly with ankyrin. It can also happen with spectrins. It can also be a result of mutations due to band3 protein. This band3, this is a vertical interaction which we have discussed already, band3 protein, or this might also happen due to mutations in this 4.2 protein, otherwise also called as something called a pallidin. So all these things are possible. So, but the most common is always your ankyrin. So this is what is very important. This is the reason why you get hereditary spherocytosis. And you can remember, once ankyrin is not placed properly, your band3 that is attached to ankyrin may also not work properly. So if spectrin is defective, your ankyrin and band3 may not be proper and may be defective as well. So mutations in one protein may also result in defective arrangement of the other proteins in the cytoskeleton as well and the membrane skeleton as well. So it's very difficult, like it's like a cascade. So don't think like mutations of that only will result in only certain issues. No, it can result in anything. That is the reason why even hereditary elliptocytosis may also be due to the same kind of mutation. So spectrin mutations can also result in elliptocytosis as well. So that is the reason why I am telling, don't be very particular about all these things. It may result in any shape of the RBC, but the RBC shape will be very aberrant in these patients. So first thing, you have known about the basics. And next thing what you have to know is, what is the inheritance? Inheritance is going to be something called autosomal dominant inheritance. Till now we have seen thalassemia, sickle cell, all these things are autosomal recessive, but this is definitely autosomal dominant in inheritance, almost 75% of the cases. There are minor cases which tend to be autosomal recessive. In approximately 25% of the cases it tends to be autosomal recessive as well. But for exam's sake, you have to remember this autosomal dominant inheritance. Where it's common is not in India, but very common in Northern Europe. That's where you're going to see this hereditary spherocytosis. In India, it's actually quite rare. You don't get this disease very often, but we have still seen certain, families having this hereditary spherocytosis, but quite rare in India. And typically, this patient, you have to look for the family history. Many patients will have a family history. What family history in exams that you have to look for is on the cholelithiasis. Sir, don't joke. Again, that's what you're asking. Sir, cholelithiasis can be seen in any human being, not like that. Childhood cholelithiasis, that is very rare. So look for the childhood cholelithiasis and look for family history of probably jaundice, maybe family history of splenectomy, because splenectomy constitutes one of the important treatment for hereditary spherocytosis. Some of the family members would have underwent splenectomy, so that might give a vital clue regarding the presence of hereditary spherocytosis. So these are some of the things that is very regularly asked in exam. Apart from that, if you ask me the clinical features of hereditary spherocytosis, clinical features, usual age of presentation, number one, or more than the age of presentation, how they present, that's what is very important. So usual presentation will be with typically anemia and jaundice. Typically has a neonatal onset result most of the time. Will be more of the, neonatal jaundice that normally happens will be very, very severe in case of hereditary spherocytosis. And you know why jaundice? It is due to extravascular hemolysis. I told you extravascular hemolysis is going to cause more increase in bilirubin compared to intravascular hemolysis. We have just seen in the previous section. At the same time, these patients may also have splenomegaly, and that is because the spleen is the principal site for extravascular hemolysis. Definitely you will have a hyperactive spleen, and because of that you might result in a splenomegaly. And these patients are highly prone for gallstones, and this is because this extravascular hemolysis is going to produce a lot of bilirubin, and this bilirubin is going to saturate the bile, causing pigmented bilirubin stones. bilirubin or otherwise called as pigmented stones. Pigment or bilirubin stones possible. And this anemia is also having a risk factor. If the anemia is long standing, chronic and severe enough, this anemia can result in leg ulcers. Again, we have seen these leg ulcers in thalassemia intermedia. We have seen in these leg ulcers with sickle cell disease. Now we are seeing these leg ulcers with hereditary spherocytosis as well. So it's a very important point again for hereditary spherocytosis. Why initially I told some point about the age of presentation, but quickly I changed into the actual features. Why? Because age is highly variable. Age of presentation is highly variable. You can't pinpointly tell what age they will present, and it always depends on the what is the severity of hereditary spherocytosis. Suppose if it's you can take 3 hereditary spherocytosis severity. One is called mild hereditary spherocytosis, which typically happens in approximately 20% of the cases. You will get mild hereditary spherocytosis, where the patient will be typically asymptomatic throughout their life. They won't have any problem at all. Second one, you have something called a moderate hereditary spherocytosis, which typically is the case in almost 75% of the cases, where the patient will be presenting in infancy and childhood. Infancy and childhood. If you ask me which is the most common variety, obviously your answer must be moderate hereditary spherocytosis, as is seen in almost 75% of the cases. Then third one, if you tell about severe hereditary spherocytosis, it's very uncommon, only in 5% of the cases, where there will be severe anemia and jaundice in the newborns itself, or you can have the fetus that dies inside the uterus itself. That's what we refer to as death in utero, where you have seen death in utero previously in thalassemia, 4 gene deletions of alpha genes, 4 alpha gene deletions, alpha thalassemia. That particular 4 gene deletion variant can result in death in utero and hydrops. So the same condition may result in severe hereditary spherocytosis also, because of severe anemia in the intrauterine life itself. So, but for our understanding, this is the most important thing, because this is what you're going to see very commonly. So that's why it's important for exams. And next thing, if they ask you how you are going to diagnose this hereditary spherocytosis, what will be the diagnosis of hereditary spherocytosis? Diagnosis, typically you will see spherocytes in the peripheral smear. Entire peripheral smear will be cooked with spherocytes. Completely it will be rammed with spherocytes in the peripheral smear. So how will you identify a spherocyte? A spherocyte is typically formed when a chunk of the membrane, because you have a biconcave shape of the RBC, where because of the damage to the membrane, certain area of the membrane may be damaged, and only this membrane may be removed by the only this membrane may be removed in circulation, or because the defective membrane, certain membrane may be shed off because the anchoring protein, because of the membrane skeleton is not correct. So because of that, they might shed off some membranes, or it can be removed while passing through the circulation. So which means it will going to result in a spherocyte. So what happens in a spherocyte is, because this membrane is the one, that is going to form the surface area of the RBC. So if lot of membranes are removed, you are going to get an RBC with a low surface area. Whenever you have a structure with low surface area, it's going to be a sphere, and that is why it's going to form a spherocyte. It's a universal law. If somebody asks you why in the universe everything is looking in round shape, everything is a sphere, sun is a sphere, your earth is a sphere, Jupiter is a sphere, or most of the celestial objects are sphere. Why? Because naturally every single object in the universe has the tendency to form objects with the least surface area. One of the classic object with the least surface area is a sphere. That's why whenever your surface area is reduced in the RBC due to removal of certain chunks of the membrane, the RBC has no other option. It has to assume a shape with the least surface area, that is a sphere. So that is the reason why you get a spherocyte in a hereditary spherocytosis. So in this RBC, what happens is the volume will be maintained because only the membrane is removed, but the actual cytosolic volume is normal. So if we take the surface area to volume ratio, the surface area is decreased, whereas the volume will be normal, which means the surface area to volume ratio will be actually decreased, which means this spherocyte has to pack all its content with a narrow surface area, which means it is going to look like as if it's hyperchromic, and you are going to result in a loss of central pallor. Loss of central pallor will be there. That is because in a small surface area, you have to manage all the volume, so the RBC becomes, it's a normal MC, which means it doesn't have any change in the volume. So volume will be normal, normal mean corpuscular volume, but everything should be jam packed in the RBC with a small surface area. So that is the reason why hemoglobin is pushed from outside towards the center, because it has to be packed, and that is the reason you result in loss of central pallor, which might appear that like RBCs that are hyperchromic in nature, because you lose the central pallor in the peripheral smear. All these things are absolutely possible, and this is the same reason why you get increased osmotic fragility as well. Why, as soon as you place even in a little bit of hypotonic solution, immediately the like RBC ruptures, because volume is relatively, the volume is very high. I mean, not exact volume, normal MC only, but relatively in a small surface area, which means the volume is jam-packed, relatively it's very high. It is like when you are sitting in a big room, suddenly you are sitting inside a box with a crampy. Your volume is not going to change, but where you are sitting is very cramped. If some other person is coming inside, it's going to burst out. The box is going to burst out. So it's like what, even small amount of water coming inside this sphere will break out. And that's the reason why this osmotic fragility by placing in hypotonic solution is very high in this patients. Osmotic fragility is very high. So all this explains, the surface area to volume ratio is going to explain all your findings in the hereditary spherocytosis. If you take about the RBC indices, if you ask about the RBC indices, so what's going to happen in this patient is your MCV will be typically normal, your MCHC may be very high. That is because of the jam-packed cytosolic content, that is jam-packed hemoglobin, which means in a small area you have a lot of hemoglobin. That's why your mean corpuscular hemoglobin concentration is high, but MCH will be normal. MCH will be normal, which means actual hemoglobin and actual volume is normal, but since it's jam-packed, the concentration and density of the hemoglobin may increase. That's why the concentration, MCHC alone, is increased in this patients, maybe more than 36%. And you might have an increased red cell distribution, with partly this is due to anisopoikilocytosis, because not only, in this hemolytic anemia, we have seen reticulocyte index may be more than 2. Reticulocytes typically have a high MCV. So you are having RBC with a normal MCV, as well as you are having a RBC with a high MCV. Because of that fact only, there might be a appearance, the variations in the size also. That is the reason why you get anisopoikilocytosis and increased red cell distribution width. So these are the RBC indices. Obviously iron indices need not talk about that. In iron indices will be completely normal, there is no doubt about that. And DCT negative. So direct Coombs test will be negative. This is a very important point, very important clue in the exam as well, because it rules out autoimmune hemolytic anemias. Because whenever you think about hemolytic anemia, that means if the reticulocyte index more than 2, the most important thing you have to rule out is a reticulocyte index more than 2. Most important thing is rule out is autoimmune hemolytic anemia. How will you rule out? By doing a DCT. Simple DCT is negative. It rules out autoimmune hemolytic anemia, which is very important DD for any hemolytic anemia. So, and again, why it's very important to rule out autoimmune hemolytic anemia is because I told you, even in autoimmune hemolytic anemia, you might see the spherocytes. In the previous video I told you also. So that is the reason why it's very, very important to do a DCT and rule out an autoimmune hemolytic anemia, because spherocytes can be seen in this autoimmune hemolytic anemia as well. But what are the other important things you have to do? 2 tests are of paramount importance for exam. One is called osmotic. So if you want to do a confirmatory test, if you want to do, the first test you can do is something called a eosin 5 malamide testing. That's called eosin 5 malamide testing. Otherwise, simply you can write as EMA or EMA binding test. And the second one, you have something called osmotic fragility test. It's a traditional test. But currently what is actually favored is the EMA, eosin 5 malamide testing only. This is what is favored for hereditary spherocytosis. What you characteristically see in eosin 5 malamide testing is something different. So what happens, this EMA is going to bind with band 3 and rhesus proteins, RH proteins. So this is where this EMA is going to bind. So suppose if this EMA binding is poor, that's what you're going to look for. So when EMA binding is very poor, so poor binding can be considered as the positive for hereditary spherocytosis, because whenever the binding is extremely poor, which means there is some membrane cytoskeleton defect, because I told you even if the anchoring defect is there, the band 3 protein will not be proper, so they can't bind with the band 3. So the binding of EMA with the spherocyte will be very poor if it is due to membrane cytoskeletal problem. If it's not due to membrane cytoskeletal problem, the spherocytes, the EMA can still bind to the spherocytes, because if it's due to AHA, autoimmune hemolytic anemia, the cytoskeleton will be normal in the, membrane cytoskeleton will be normal, so EMA can still bind. But in hereditary spherocytosis, it cannot bind because the membrane cytoskeleton is abnormal. This is how you differentiate spherocytes due to AHA and other causes. This is how this is how you tell that it's spherocytosis due to hereditary spherocytosis. So number one point is reduced EMA binding to the spherocytes or to the RBCs in general. Second thing is the traditional osmotic fragilities. And what are the advantages of EMA? Why it is considered as very highly regarded nowadays is because sensitivity of the test is very high, it's approximately 93%, and specificity of the test is again very high, approximately 99% specificity, compared to OFT, which is having very poor specificity and sensitivity. But even though traditionally regarded as one of the important tests, but very poor sensitivity and specificity, EMA is having extraordinarily high sensitivity and specificity. That is why it is the preferred and the best test in the current era if you want to diagnose hereditary spherocytosis. And one more advantage of EMA is available within 2 hours, whereas OFT has to be done for 24-48 hours sometimes. But here it's not a cumbersome process, very time consuming. Here it's not time consuming, relatively easy if you have a flow cytometer, and just within 2 hours you can get the results within 2 hours. And you need only small quantity, which means in OFT you need a large quantity of blood. In already anemic patient, you have to think twice, but this patient needs only a small quantity of blood. Very fast results, small quantity of blood. All these things tells you that like this EMA is one of the best and preferred tests in case of hereditary spherocytosis. So what will be the OFT? I'll come back to you. Don't worry about that. I'll be coming back to OFT again. But before that, let us see what will be the finding in EMA, peripheral smear finding and EMA finding. So this slide shows you that the findings in hereditary spherocytosis. Number one, this is a peripheral smear. You can see a lot of spherocytes. These are all spherocytes. There is no central pallor. There is no central pallor. Amidst many normal RBCs, you can see with a good central pallor. At the same time, you can see slightly bigger RBCs. These are little bit polychromatophilic. You can see this RBC. Polychromatophilic means little basophilic content is there. Little basophils are there. This indicates little basophilic. This indicates these are reticulocytes. These are reticulocytes, and you should not call basophilic actually. Instead, you can call it as these are polychromatophilic. You can see little bit blue in color, polychromatophilic, and which means they are actually nothing but reticulocytes in the peripheral smear. So you are seeing a combination of spherocytes with a lot of reticulocytes in the peripheral smear is going to tell you that this is a hemolytic anemia. That's all. This is some hemolytic anemia going on. That's it. It could be autoimmune, it could be even sometimes a microangiopathic hemolytic anemia, it could be hereditary spherocytosis, it could be anything. So that is the reason if you strongly suspect a hereditary spherocytosis by clinical history and family history, next step is to move towards EMA. How will you do an EMA is through a flow cytometer. There is a flow cytometry. In a flow cytometry, what you are typically going to see, I have given two things. One is the binding of the EMA. The binding of the EMA tends to be eosin 5 malamate binding tends to be normal peak. So it means lot of RBCs will have normal EMA binding if it's a normal. But if it's hereditary spherocytosis, you can see reduced binding. You can see the peak is reduced and the area is also reduced. So you can see reduced EMA binding if the patient is suffering from hereditary spherocytosis. That is why EMA binding by flow cytometry is the current gold standard for diagnosing hereditary spherocytosis. As simple as that. So then if you want to prove the osmotic fragility, so how will you prove the osmotic fragility is by the next step. So this is the osmotic fragility test. This is what we refer to as something called an OFT, osmotic fragility test. How can you prove this is by the following technique. So I have shown in the picture itself. So the reason why the spherocytes are osmotically fragile is, again I told you, the surface area by volume ratio will be very less, which means even if you give a small amount of extra volume to this RBC, this is going to rupture and they're going to lyse. And how we are going to do that is by placing in a serial hypertonic solution, not by placing, like in an Nesterov test in thalassemia, we are placing a single 0.36% buffered solvent hypertonic solution. But in this, we are not going to place in a single solution, we are going to place in a series of solutions, and we are going to note the amount of hemolysis in particular solution. So, and we are going to plot a graph. That's what's going to happen. Amount of hemolysis in a particular solution can be assessed easily by a spectrophotometer and all. So, it's very easy to find out. So, that's not a big deal. You have a separate machine for that. So, idea is to place, take a different concentration of hypertonic solutions ranging from 0.9 to 0.1 or even up to 0% and put the blood in all the hypertonic salines and see the amount of hemolysis in each and every test tube. It's a cumbersome and time taking process, but still it's worth knowing. So that is what is given. Here you can see the hemolysis, this is the 0.85% saline, 0.75, 0.65, 0.6, 0.5, 0.55, 0.5, 0.45, 0.4, 0.35, 0.3, 0.2, 0.1. So I made most important point, that is serial hypertonic solutions. Serial hypertonic solutions. And next thing, what you are seeing when you place in a serial hypertonic solutions, you are actually finding out the extent of hemolysis. What is the hemolysis? Don't worry about this non-incubate, incubate and all. So what is the hemolysis you are seeing in this patient? So what is the hemolysis seeing in this patient? Usually till you can see in the 0.55 mark, your hemolysis is actually 0%. You didn't get even a hemolysis. Actually, it starts around your 0.5%, 0.50. That is usually the normal thing. Usually hemolysis in normal RBC starts around 0.5 to 0.55%, or some books will tell you 0.5 to 0.6, but somewhere around 0.5 to 0.6 or 0.5 to 0.55%, that is where your hemolysis should actually start, in this zone only. So then usually hemolysis will be complete by around 0.3 to 0.33%. When you take this 0.3% to 0.33%, this is where the hemolysis is complete. You can see full black there. So hemolysis will be complete. So hemolysis typically starts around this 0.5% mark and typically becomes complete by 0.3 to 0.33% mark. So this is what the idea is. And you can plot this in a graph. You can see the graph and the percentage of hemolysis. Here you can put the percentage of hemolysis here, and you can take the saline concentration here. You can see this is the normal range. You can see this is what happens. So I can put the normal range over here. This is a normal range in these patients. Clear? So this is what is going to be the normal range. So you are not going to have any hemolysis. For example, at a range of till you get this 0.7 or 0.5%, there is no hemolysis. No hemolysis in normal patients. Hemolysis typically starts around this 0.6, 0.5% mark. Typically in exam, remember 0.5, and it increases, and hemolysis will be complete by around 0.3% mark. Usually that's what happens. But if you see in a patient with hereditary spherocytosis, this is a patient with hereditary spherocytosis. You can put in red color. This is a patient with hereditary spherocytosis. You can see the hemolysis is going to start much earlier. Here you can see the hemolysis starts at around 0.65 to 0.6% itself, and it's actually complete by around 0.5% itself. 0.5% itself in this example, it is complete hemolysis. So the exact values, even though in the books it's given, it's not at all important. You have to plot in the graph. That's what is more important. So if you plot in the graph, you can see a completely different graph in hereditary spherocytosis patients, where this is the patient with hereditary spherocytosis, this red line which I have drawn, where the hemolysis starts much earlier at around 0.7, 0.8% itself, and it goes up, and the hemolysis is complete by around 0.6% mark itself, around 0.5, 0.6, where the hemolysis typically starts in a normal patient, is actually quite complete in a patient with hereditary spherocytosis. So why this point is very important? Because in certain conditions, certain normal patients itself, the hemolysis may begin later also, but it might end at 0.6 percentage itself in certain patients. So that is why it's highly variable, where it starts and where it ends. Even though for exam sake it's very important, it might start at, typically in exam it's 0.5 percentage and it ends at approximately 0.3 percentage. So this is what the exam point for normal patients. And in hereditary spherocytosis, it usually starts at 0.6 percentage itself and completes at 0.5 percentage. More than 0.6 it starts and completes at 0.5 percentage. So which means even though for exam these things have been given, but these things are actually really not important, because there is considerable variability depending on individual variability in the membrane skeleton and cytoskeleton. So you cannot take these values as granted. That is the reason why the graphical way of representation is the best way. So you always have a control graph in this, and then you plot the graph of the hereditary spherocytosis. I mean, in a case of suspected hereditary spherocytosis, if the graph is completely different compared to that of the control, and the hemolysis starting much earlier and ending much earlier, that is what is going to tell you that the patient is suffering from hereditary spherocytosis, not the actual exact value. So plot a graph always, that is what the key is. So anyway, the osmotic fragility test is nowadays outdated. It's not being done in many centers because of the cumbersome nature and considerable user-to-user variability of this test, and a lot of bias is there, and observer interpretation variability will be there. A lot of things are there problematic with this OFT test. That is the reason why many centers don't perform this OFT in the recent times. So if you ask me the sensitivity of OFT, it's approximately 80%. The specificity is much lesser. Specificity is approximately only 50 to 60% for an OFT. So which means it's much inferior compared to that of the EMA binding. So whenever in doubt, you always prefer EMA binding if it's available. If it's not available, then you might be preferring a osmotic fragility test, which is not at all sensitive or specific. And remember, whenever you use a OFT, always use a whole blood. And if they ask you what anticoagulant you will use, traditionally, because why this is important, because traditionally I've been asked this question, it's heparin. Heparin is the traditional anticoagulant of choice that you have to use while you are collecting blood for a testing for a OFT test. Currently even K2-EDTA is also preferred, but traditional answer of choice is heparin. But even a lot of studies still K2-EDTA is also a very good excellent choice. But anyways, let us go to the treatment part. So what will be the treatment of hereditary spherocytosis? If you ask about treatment of hereditary spherocytosis, the only definitive treatment is always splenectomy. There is no other doubt. Splenectomy can completely cure the hemolysis, but whether it's performed or not is the question. Generally, it is not performed. General supportive treatment with folate is given. I told you already, folate is given for all hemolytic anemias, any chronic hemolysis, because turnover will be very high, and to support the high turnover in the bone marrow, you have to give folate. Definitely, there is no doubt about that. So you can give transfusions. Again, this is not the mainstay of treatment. Transfusions are only used for, like severe anemias in acute cases, just to improve the symptoms of the patient. Apart from that, there is no role for transfusions. Third thing is a splenectomy. Remember, splenectomy can cure the disease. This is the only cure. This is the only curative treatment available. Completely cure the disease. Remember, it will not cure the spherocytes. It will cure the hemolysis. It will cure the hemolysis. Definitely. But spherocytes will persist because of membrane abnormality. There is no doubt about that. Spherocytes generally persist after splenectomy. There is no doubt spherocytes to disappear. It will persist after splenectomy, but it cures the hemolysis and the associated complications. Anemia, gallstones, your abdominal pain due to splenectomy, then your leg ulcers, a lot of things will disappear, and risk of chronic heart failure, high output cardiac failure, all these things will reduce with splenectomy. So that's why splenectomy cures the hemolysis and the disease itself, but the spherocytes will persist even after hemolysis. So what are the indications? Major indication is a transfusion dependency. So what do you mean by transfusion dependency? Which means because of severe anemia, you transfuse the patient with a PRBC. Within a few months time or a few days time or a few weeks time, the patient comes back with severe anemia because all the RBs are again gone. So transfusion dependency, which means this is the most important indication. This is the most important indication for splenectomy for hereditary spherocytosis. If you ask me about the minor indications, minor indication that is due to retarded growth. If you ask me why retarded growth can happen, yes, it can happen in hereditary spherocytosis because of the high RBC turnover. that might consume a lot of energy, and because of that you might have a stunted growth. So retarded growth is another minor indication if the growth is poor in a child, or if the patient is having chronic abdominal pain due to splenomegaly. So in these conditions you can do a splenectomy as well, but many people do not do splenectomy in this for these indications. They somehow try to manage with conservative measures itself. Typically a hematologist prefers for splenectomy only for this indication, that is transfusion dependency. And de novo splenectomy is a curative treatment in case of hereditary spherocytosis. And one more interesting point is, suppose if the patient is having persisting anemia, you have done a splenectomy, still the patient is suffering from persisting anemia, and patient is suffering from persistent hemolysis even after doing a splenectomy. What do you think about? So this is a very standard question in exam. If the patient is having persisting hemolysis or persisting anemia, even after doing a splenectomy for hereditary spherocytosis, look for accessory spleen. So that might be keeping on killing the RBCs and phagocytosing the RBCs. So look for the accessory spleen, which is a very important point again. Next thing, a minor topic, that is hereditary elliptocytosis. That's a very rare entity. So the problem in hereditary elliptocytosis is most commonly due to mutations of spectrin. In that also they will ask you what spectrin mutation, that is alpha spectrin very commonly than beta spectrin. I told you hereditary spherocytosis is due to anchoring mutations very commonly, but elliptocytosis is due to spectrin mutation is extremely common. So what will be the typical feature? Peripheral smear will show elliptocytes. If you want to see how elliptocytes look like, look at the basics of RBC, where I have showed an entire template on dysmorphic RBCs. So elliptocytes more than or equal to 25% in the peripheral smear. So this confirms that the patient is having a lot of elliptocytes, hereditary elliptocytosis. Whether it is something serious or not, no. Patient will, this condition is typically a very, very benign condition. Most of the times patient will have only mild bilirubin elevation, unconjugated predominantly, a very mild splenomegaly and a mild hemolytic anemia with a mild increase in reticulocyte count and index. So this is what usually hereditary spherocytosis is all about. But in general, you don't get a severe disease if the disease is very severe enough. Only curative option is again splenectomy, but generally not needed since it's a very benign disease. If in case if it's severe disease is seen in a patient, you might go for a splenectomy as an option. Exceptionally severe case, apart from that you don't need to do anything at all in this particular patient. So these are the important two things that happen due to membrane defects, which is again intrinsic or corpuscular RBC defects causing hemolysis. The next section we are going to deal is on the enzyme deficiencies causing hemolysis, which will be in the next section.